Thank you all. I'm thrilled to be here in the beautiful state of Louisiana, and I thank Brian for that kind introduction. So before we get started, I just want to give a thanks to all of you for being here. I'm sure there are other things you could be doing, so thanks for being here tonight. And I just want to thank Dr. Redfield and Mrs. Carol and Brian as well, who I know really make this possible, and for Brian for inviting me and for being so kind, picking me up from the airport and driving me around and making reservations. He's incredibly busy, so thank you. I don't have any disclosures. So I just want to start with a quote from Stanley Hauerwas. So Stanley Hauerwas, as you know, many of you know, is an American theologian. And he said one time that medicine and religion are interrelated, cannot be avoided. The interesting project is understanding how. And so my goal tonight of my talk is pretty simple, right? To remind us, how are medicine and religion interrelated? Not only that, because this is an audience I think of friendlies here, but for those of us that speak about medicine and religion, maybe to audiences who don't feel the same way we do, how can we talk about this in a way that will get people's attention, right? I am at the University of Michigan, like Brian said, we're a public institution, and I've had to remind my colleagues of how important religion is to us as healthcare providers, to our patients. And whenever you talk about something that you care deeply about and you want others to care deeply about, right, it's important to hook your topic into something they say they care about already, okay? So I'm going to talk to you about how I've talked about medicine and religion at my place and other places as this topic relates to three things. Patient-centered care. We all say we care about patient-centered care. This topic fits into that topic, right? Physician burnout. Huge crisis, not only in physicians, but healthcare providers. Medicine, religion, spirituality fit into burnout. And also when we say we care about diversity, equity, and inclusion. Religious diversity is a very underappreciated aspect of diversity. And so this topic fits into that as well. And we need to be reminded that religion is inherently involved in the vocation of medicine for many reasons that I'm sure you understand. But I've noticed as I've progressed through my medical training that what Jeff Bishop says is true, right? That medicine has become forgetful of anything metaphysical, right? We have become very forgetful of anything that exceeds the material world, the transcendentals, truth, beauty, and goodness, as Brian was just talking about. So we need to be reminded. What's the importance of being reminded? Well, we are taking care of the image bearers of God. There is, outside of being clergy or a parent, these are 3 of my 4 boys in the very cold Lake Michigan in June. They're never afraid of the cold water. We are taking care of the image bearers. This is such important work. And patients come to us. I'm an internist, so I take care of adult patients over time. Patients come to us in the time of greatest need, and they have existential questions that arise in the course of illness. And are we being attended to those as we should, right? How to become reacquainted with how to become comfortable to domains of suffering that exceed the biomedical space, right? How do we attend to spiritual distress that we'll talk about today? Provide religious accommodation. If we say that we want to take care of persons and not just machines, we are not technicians taking care of complex machines, right? We are human beings taking care of the image bearers of God. And so we're going to be talking about patient care first as we talk about our concepts today. And what I see oftentimes in medicine, I teach medical students, I teach residents, oftentimes give talks to fellows and attendings. People go into medicine mostly, I would say, in the healthcare professions, take care of human beings, take care of persons. And then you hear the language shift, right? Like later on, you hear people say, well, as they get maybe a specialty interest, they'll say something like, I'm in medicine to take care of people with diabetes. And you'll hear people shift and say, I'm in medicine to take care of diabetics, right? All of a sudden, the person is the disease. And then later on, as people become really focused, I'm in medicine to manage diabetes. The person has become totally left behind, right? And we wonder why people are struggling with burnout in medicine. They've lost, right, a sense of meaning of being reminded that they're being taken care of, the image bearers. And so tonight we're going to talk about how medicine relates to a religion and specifically patient-centered care, whole person care, right? We strive to take care of people in all the ways that they may suffer or that they may feel pain. We're also going to briefly touch on how this topic fits in with provider burnout, and also at the end briefly about diversity, equity, inclusion, especially when we think about the space of bioethics and making a claim that those of us that have a theological worldview, not only do we deserve a seat at the table because of reasons that I'll, and you know, explain to you, we have something really radical, countercultural, important to say into the space of bioethics, especially if we care about preserving the important notion that all human beings have equal value and worth because they're the image bearers. So because this is like more of the academic talk tonight, tomorrow is more of like a personal talk about a theology of medicine, I have to sort of start with some definitions. And usually I'm talking to people who really are not a friendly sort of audience, and I have to sort of get them sort of warmed up. I'm sure you all know sort of what spirituality is, but whenever I talk about spirituality in some circles, people get completely freaked out, you know, like, what are you talking about? And if you're freaked out by that topic, really the word spirituality comes down to meaning. And I heard such a fabulous talk one time at the Conference on Medicine and Religion by Dan Sulmasy. Many of you may know him. He's a Catholic physician. He runs the Kennedy Center of Ethics at Georgetown. And Dan said, all illness is a spiritual event, because all illness is a disruptor or potential disruptor of relationships. And all relationships are steeped in meaning. And it was a beautiful talk about talking about how illness can disrupt your relationship with, you know, your family, your work, right, which gives you meaning. Your relationship maybe with the divine, you struggle with, God, why is this happening to me, right? And as a scientist, he even talked about how there's a disruption at the level of the cell. Right, if you think about cancer, right, which is a disruption that happens at the cellular level where cells are like obviously not respecting the normal boundaries and transgressing the normal sort of barriers that cells respect, there's this disruption, right? So we want to think about spirituality in terms of what it means. It comes down to is really anchored in meaning. And yes, people who have a religious worldview, they're going to anchor their meaning making through a specific religion, but people can find meaning and spirituality within nature, right, within music. We are meaning-making creatures. And people come to us in medicine with an explanatory model of illness, right? It's basically how they make sense of what's happening to them. And oftentimes, right, they're going to have a sense of meaning that maybe is threatened in their illness, or they make meaning through their illness. So we have to think about all illness really through this spiritual lens. My theologian friends get like totally freaked out if I try to define religion. They say you can't do it, but I sort of have to for a talk like this. So Koenig at Duke says that obviously religion is a system of beliefs, right, through which a community or individual communicates with the divine. All right. So when I talk to people and I'm talking to healthcare providers, they're like, you know, Collier, you're like, no one believes in God anymore. Like, this is a topic that's totally some zebra. Like, this doesn't relate to your patients. Well, actually, like, the data doesn't really support that. The Pew Research says actually that when they've asked U.S. Americans a couple years ago, you know, do you believe in God? 80% of U.S. Americans said, yep, I believe in God. Most of them said they believed in the God as described in the scriptures. About a quarter of them said they believe in some other spiritual power or higher force. But even the group that said, like, no, I don't believe in God, about half of them still believe in some type of higher power or spiritual force. So based on this data, right, about 90% of people believe in some type of like higher power or God or spiritual force, right? So our patients, right, have these beliefs, right? And if you look at certain populations, especially certain populations we're called to care for in medicine, minoritized populations, et cetera, you'll see that they're highly religious. They believe in God with absolute certainty. They say religion's super important. They pray every day, and they're attending service. So what difference does that make to our patients? Okay, like, well, if you look at people's attitudes, actually, people believe that God, intervenes in their life, right? Half of US adults believe God determines what happens to them most or all of the time. They believe God has protected them, right? Or rewarded them. And why that's important is because if you look at our patients and about US Americans, right, they're not deists, right? They don't believe that, God created the world like some clock and like plopped it down, right? And it just sort of runs and he's like uninvolved. They're theists. They really believe that God's like involved. And again, why that matters to our patients is because, again, when patients have their explanatory model of illness, which is the narrative they tell themselves is how they make sense or meaning of their illness, God's involved in that narrative, right? God is involved in their cancer, in their relapse, as if they get better or not. They believe God is involved in like their entire course with us. And it would just be an impoverished, I think, care plan if I didn't realize that people have these beliefs. If I don't know, right, that people are using their faith as a way to cope or make sense of their illness, or maybe they have spiritual struggle, right? Any care plan, if we're going to make a patient-centered care plan that does not take into account people's most deeply held commitments, is an impoverished care plan, right? So our patients really believe in most of them in a divine power that's somewhat interacting right with their day-to-day lives. We should be attentive to those beliefs. So many of you probably are aware of Cicely Saunders, and Cicely Saunders was amazing. She trained as a nurse and then went to medical training, became a physician. And she's considered to be, I would say most people consider her to be the mother of modern day palliative medicine. And so Dr. Saunders has this model that I saw for the first time only a few years ago. I don't know why I didn't see it before that, but whatever. So this is a model, right, that's called her model of total pain. So Cicely Saunders says people experience pain, suffering, or wellness in like 4 intersecting domains, right? Physical, psychological, social, and spiritual, and they all intersect. So if you have a patient, for example, that has like undertreated or untreated spiritual distress at the end of life, they're going to have really difficult sometimes to manage physical pain that isn't really responsive to traditional pain medications until you have your clergy or chaplains help address their spiritual struggle. Just like, there's a commercial a few years ago for depression medication, and it said, like, where does depression hurt? It hurts all over, right? So we know that people that have undertreated or untreated mental health difficulties, they oftentimes present with more physical pain complaints, right? And so all these quadrants intersect. So when I saw this a few years ago, I said, okay, I went to a pretty top medical school and residency program, and I feel pretty confident being able to recognize what physical sort of suffering is. I'm pretty good with like picking up psychological suffering, but I was like, social suffering, like spiritual suffering, like what even is that? Like I had no clue what that was, and I had no way to like assess for that. I had no way to understand if I did pick that up, like what to do with that. And I honestly felt a sense of shame. Like I'm a general internist, and basically I was seeing like half of my patient, My patients had these other struggles, and like for most of my career, actually, I frankly didn't care because I was a total materialist and I was an anti-theist. But then, like, once I sort of became had a conversion and I was a Christian and I saw this model, then I was like, boy, I don't know how to I want to understand what these domains look like, and I just don't know how. And I've made it for the past like 5 years my professional sort of mission to like understand how to take a spiritual history, how to use my interprofessional team, right? Because the struggles are there, and it's our job to be able to pick them up and get the patient the help that they need and deserve, whatever domain it's in, especially if we say we care about whole person care. So what does this look like? What does spiritual distress look like? So I run, as Brian said, a program at the medical school on health, spirituality, and religion. And in that program, we have curriculum. And we have 2 electives when the students are in their 4th year of medical school. One's in the ICU with our chaplains called the Healing Presence. And one is like a non-clinical elective where we do like reading and writing and discussion about like theology of the body and such. And so at the end of the elective, the final project is a question. So the students are given the question, is medicine a spiritual practice? And they can answer that question with sculpture, with art, with music, with an essay if they want to. They can use any sort of medium that they want. And so we had a Buddhist student who took the elective last year, and this was her final project. And it's like so amazing, first of all. I was like, I can't believe she made this, but she did. So there's this patient, right, that she sculpted with, their head in their hands, and you probably can't tell, but in the middle there's like a heart that has this sort of red sort of glitter. And then the person's sitting with like a shadow, and in the shadow are questions that she learned that people can experience as part of spiritual distress. And the questions are like, why is God doing this to me? Am I all right with God? What happens when I die? What kind of meaning will my life have now without my leg? Questions that people have. And our patients have these questions. And oftentimes, they struggle silently with this because they don't feel like they can bring this up to our healthcare teams, or they feel like their healthcare teams will judge them in some way if they reveal these struggles. And oftentimes, honestly, in certain points of people's illness, these are the kind of struggles and questions that sometimes are more important to our patients than some of the other biomedical stuff that we focus on. And I just thought that was a really beautiful example of people like, what is spiritual distress? It's these types of existential questions where meaning, right, comes out. So in 2015, 2016, I was teaching a course at the University of Michigan to freshman students. These were undergrads, which was super fun because they were like 18. You know, I'm used to teaching like older people. And the name of the class was Fearfully and Wonderfully Made, Themes of Medicine in the Old New Testament. So I taught that class for a couple years. And when I was teaching that class, I used this book by Dan Hinshaw as one of our textbooks. And it's so fabulous. It's called Suffering, the Nature of Healing. And Dan is a really amazing man. So Dan is trained as a general surgeon and then does something that not a whole lot of people do. He went back to training in his 40s and trained as a palliative med doc and left general surgery. And he's an Eastern Orthodox man who's just really, really quite wise. I learned a ton from him. And so in his book, he had this quote from R.J. Bolger, who wrote this piece in JAMA at the turn of the century called The Quest for the Therapeutic Organization. The quote is, "The greatest challenge facing the academic health center community is to restore the marriage between humanistic concerns and scientific and technical excellence in healthcare delivery practices." When I read that, I was so motivated by this statement. It's become like my professional mission statement. I sort of have it tacked up on my corkboard at work. And I read that, I'm like, boy, this is talking to us, this is talking to me. I'm at an academic healthcare center, right? And he's saying that this isn't like one challenge that we have or one of many challenges. He says this is the greatest challenge we have, right? Is to restore, right, this relationship, like Harhaus talks about, between humanistic concerns and scientific excellence, right? And I have a grant in something called narrative medicine, which is where we sort of reclaim patient stories and patient care, and I love language and narratives and such. But so the words in this quote really speak to me about, like, he says we need to restore it. You know how I said we need to be reminded? Like, this relationship was at one point intact and it's been broken. And even that word marriage implies this intimacy between the humanistic concerns and the scientific excellence. I think of Cicely Saunders' model of this intersection. And why have we made it seem like, because of bias or misunderstanding or because of the hidden curriculum, that for us to sort of progress in medicine with our scientific and technical excellence, that we have to like leave these other skills behind? Like, why are these other skills of trying to be like empathetic with patients or addressing spiritual distress or seeing persons in the fullness of their humanity? Why are those considered like soft skills, or people like eye roll if we have lectures about that? This is the kind of stuff that we need to be focusing on if we want to attend to the challenge that Bolger tells us we need to be doing as an academic health center community. And so then you're like, all right, well, that sounds like really fine and everything, but do patients really want us asking them these questions? And so many of you probably know Far Curlin. He was at Chicago, now he's at Duke, and he and his team at University of Chicago a few years ago looked at their inpatients at University of Chicago and said, you know, do the patients sort of want us to sort of address their religious and spiritual concerns? And like 41% of the inpatients desired a discussion of religious and spiritual concerns while the hospitalized, but only about half of the patients said they had an opportunity to do so. And so when we see this, we see a gap in care. Patients want something, and we're not providing it, and it really aligns with the mission of what we should be doing. We should be doing something about this, right? And we don't have time today in this lecture, but you know, I know Jeff has spoken here before. So if you want to understand like how this happened, The Anticipatory Corpse is such a great book. This is required reading, as you probably know, from many medical schools. And Jeff is a Catholic physician who's an internist. He's an MD PhD. He runs the ethics group at SLU. So he talks about the Anticipatory Corpse, and Jeff is sort of like a very cool philosopher guy. So Jeff says, right, that medicine, because of this historical sort of path, he talked about Foucault, and several centuries ago, especially in France, there was like this growing distrust of the church, right? And because of that, they wanted, you know, medicine wanted to sort of like distance itself from anything related to like metaphysics, right? And in the progress of that, this turn towards this clinical gaze Jeff talks about has become so stripped away of anything that we can't examine under a microscope. And again, this is sort of the stretch. Jeff says actually that the dead body has become normative in medicine. And so he said that's why the students actually start in gross anatomy lab dissecting a dead body. The dead body is normative. And so he talks about this to sort of show us this path in medicine. And it's actually really interesting because when I first read this book a few years ago, I'm like, Jeff, that's like really extreme. Like, I really don't think that's true. And actually, like, the more I have my eyes open to that now, the more I see that that is true. So thinking about this in ethics, what does this look like? Thinking about medicine not being at all attendant or caring or recognized of transcendent or metaphysical goods. So I'm going to change the details of this is not a picture of a real patient of mine, but I'm going to tell a story of a patient of mine. I'll call her Mrs. Wheaton. So Mrs. Wheaton was my patient. I took care of her for, since I was a resident, so 20-some years ago. I've been taking care of her for all that time. She's in her 80s, and she has some chronic medical conditions that we're managing together best we can. I also took care of her husband until he died of an acute aortic dissection at church a couple of years ago. And so Mrs. Wheaton was a widow, really close to her really large family. She was a woman who was like really filled with faith. And so we were taking care of her. I was taking care of her, and she was doing fine until it was like the summer of 2020, when the pandemic was really in full force. And so her daughter called me and said, Kristin, I'm worried about my mom. I need you to see her. And I was like, yeah, absolutely, bring her in. We'll take a look at her and talk to her. And the daughter said, I can't bring her in because she hasn't been able to walk for the past couple weeks. And so I was really concerned, and we actually set up a video visit, and we had just started putting these video visits up because of COVID, so we both were trying to learn the technology. So I have the video visit. I have Mrs. Wheaton on the screen, and she's in her recliner, and she's surrounded by her animals and her family and her grandchildren and great-grandchildren. And we talked. And after a few minutes, I was pretty convinced that Mrs. Wheaton actually had cord compression, which is spinal cord compression, which is where the spinal cord actually gets pushed upon by usually a malignant tumor. And if you don't get sort of emergent radiation therapy to sort of decompress the cord, you can have paralysis and die with paralysis. It's actually quite awful. And so I explained that to Mrs. Wheaton. I was like, I'm pretty concerned, that you have an acute sort of neurologic emergency we call cord compression. This is what I think is going on based on what I can see and what we can sort of hear from you. And I said, you need to go to the ER. And so she looked at the camera and she said, Kristin, I'm not going to the ER. And I said, well, why is that, And she said, because of the visitor policy. So our hospital, every hospital probably, right, across the country in summer of 2020, had restricted visitors for our adult patients in the hospital. And so she knew very well if she went in that hospital, and I think she knew she was dying, But if she went in, she'd be by herself. Our hospital, if you were actively dying, you were allowed one person. That's it. Even if you were dying, right? So she knew she wouldn't see her family probably again, And she was 88, right? She had difficulty hearing, some difficulty communicating. She knew she would struggle in the hospital. And so, we talked about what that would mean for her, the risks and benefits of that, shared decision making. Did she fully understand? She said she did, and her family totally supported her, And so she didn't go, She ended up dying at home. We got home hospice for her, and she died within 2 weeks. And so, when I was so, I totally get the visitor policies. I contracted COVID in March of 2020, taking care of a COVID positive patient. I was sick for months, and it was just awful. So I in no way want to discount how important the policies are. But so many of the policies that came out in the pandemic were totally forgetful of any metaphysical goods or other goods that exceeded sort of the goal of reducing the risk of infection of COVID-19 above all other things, right? How can you value or put a price upon or on these scales in bioethics, which really doesn't work, the importance of administering last rites, right, in the hospital, or the anointing of the sick, or attending a funeral mass, right? These things were completely not even recognized, And so Brian talked about a piece that I wrote in America Magazine. So I wrote this piece a few months after this had happened. Actually, I tweeted about the visitor policies being, I think, disproportionately affecting my older patients and certain patients that had disability. And so someone at America Magazine contacted me through Twitter and was like, do you want to write this piece? And I was like, yeah. So I wrote this piece about how, I think the root problem is in medicine, we haven't really trained doctors to value sort of human life in a proper way. And this may be very unpopular at my place because I criticize Michigan Medicine's visitor policies, but to be fair, I criticize everyone's visitor policies. But what's really encouraging was that actually a lot of people reached out to me across the country and said, I took your piece to my hospital ethics committee and we got our visitor policies changed. So that was really good. So my team looked to see, like, why are we not doing a better job of addressing people's religious and spiritual concerns, whether it be spiritual distress, et cetera. And so I did this research with my colleagues, Dr. Wright's head of our chaplain department. Kristin was a trainee. He's an internist at Cleveland Clinic now. And Phil Choi. Phil Choi is a critical care physician. So this piece was published in the American Journal of Hospital Medicine a couple years ago. But basically, Dr. Phil Choi, when he was at Duke, he asked his ICU colleagues down there, like, do you address patients' religious and spiritual needs? Is it important, you think, to do so? Is it your job, and do you feel trained? And the doctors down there surprisingly said they felt like trained to do it. They thought, yep, this is important. We want to do it, but they said we're not doing it, you know? So then we did our study to like figure out why. So we did surveys and qualitative, like semi-structured interviews with our ICU adult docs at the hospital and fellows. And we found like these themes that emerge. And so theme one was really interesting, sort of discomfort with discordant views. So if the physician or the healthcare provider had a worldview or religious faith that was very different from the patients that they saw, they totally just like freaked out, like couldn't address, like, and they just didn't, they chose to like not engage with the patient, which is a huge problem because actually, I don't know if you know, in Michigan actually, we have a very large percentage of Muslim Americans actually in Dearborn, Michigan, and they tell us they come to our hospital and they sometimes feel like they are discriminated against or judged in a way because of the way they make decisions as a group and oftentimes defer to certain members of the community and such. So someone said, you know, this is one of the physicians, I think I'm really fearful of based on my own insecurities, which is like offending someone, you know? Like saying something like, oh shoot, like I put my foot in my mouth, that kind of thing. So I'm really not the most comfortable specifically with like maybe faith groups I'm not familiar with. You know, we've had several people of like the Muslim faith in the ICU and that was sort of new to me and it was like, I really don't know what to say and I'm worried if I say, you know, so I don't know, probably it's my own insecurity. So physicians in general really don't like to sort of make it seem like they don't know what they're talking about. So like they just sort of avoided the patient's like needs and such. It was funny, I had like a resident come down to my office like a few months ago and she's like, Dr. Collier, like we have this man and he's in the ICU, he's a Muslim man and you know, he has like electrical storm and he was like this arrhythmia and he has this ICD and the family, you know, basically is having this discussion about like whether or not we should turn the defibrillator off and she's like, I just have like a sense that like their faith is like influencing the way they make medical decisions. I'm like, yeah, probably that's true. Like, let's talk about how to like engage. Like, why are you down here? Let's go upstairs, you know? This reminds me of Abraham Nussbaum. So he's, I think Abraham's Catholic. He's a psychiatrist out in Denver. And he wrote this book called The Finest Traditions of My Calling, right? And so in the book, he says, when no one asks about something, you learn that it's not important. So if our patients come to Michigan Medicine, let's say, or to your healthcare system, and no one ever asks them any questions that exceed the biomedical domain. Like all you ask them about like their lab work and their heart rate and their respiratory rate and what's your creatinine and what's your phosphorus. I mean, those are important details, right? But again, we're not supposed to see our patients as like organic plumbing, right? They're so much more than that. Our patients are gonna say, you know, this is just the health system or this is the doctor. They just don't care about these other things, right? And if your trainees, your students, your residents, never hear you ask them, hey, you know, I just heard a lot about Mrs. So-and-so's, you know, lab values, but how is she doing, you know? Have you taken a spiritual history? Does she have any other concerns, right? Then they're going to say, oh, well, this is something I learned in school, but this isn't something real doctors do, or this isn't my job, or this isn't something that, like, I need to worry about, right? Reminds me of a story of a patient. I saw a patient, like, I was baptized 5 years ago, so this was probably like 6 years ago. So 7 years ago, I was like upstairs. I'll just never forget this man. So he was a man that was, I saw a man upstairs on our hemonc service. And I went upstairs to see him with my student. I work with the MD PhD students. And I was up there with him and I was watching him do like a history and physical on a patient. And so it was a man that we were interviewing. He was like probably 30 and he was in the hospital with AML, which is like an acute leukemia. And when you have AML, you get like induction chemotherapy and you're in the hospital for like a long time, right? It's like so awful. And so we took the history and physical and I watched my student and I gave him feedback and it went really, really well, whatever. And then I saw this like statue on the patient's windowsill, like I didn't know what it was. And so I asked the man, I said, do you mind if I ask you about the statue on your windowsill? And he was like, oh yes, you know, and I said, can you tell us about it? And he told me it was like Our Lady of Guadalupe, and he was a Catholic, and he believed the Blessed Mother was like watching over him. We saw like this really different, beautiful side of the patient that emerged when he was telling us about this. And after we were done sort of chatting, he's like, I've been in this hospital for a month, and you guys are the first people that have even asked me about this. And I just like, again, had this like sense of like shame, like what is going on? We operationally make it seem like God doesn't exist in the halls of our hospital. Of course he is there, right? But like we make every attempt possible to make it seem like he's not, or he's not welcome. So I see it now, because I have like a different mind now, right? I see it now when you go round on patients, or you see patients, and sometimes they'll have like the scriptures, or they'll have like a rosary, or they'll have like a religious object, and the team walks in, they'll sort of put it away, because they're like, they think, which is probably true in some instances, hopefully not the majority of the instances, like we're going to judge them in a way, or think of them in a way that they think is unfavorable, and they want to be seen as favorable by their healthcare provider, and it's just like, what is going on, right? So theme 2 is specialization. So medicine, this is a double-edged sword, right? Medicine has become so subspecialized because of how complicated everything is, and I think there's some good things in that, but as some of us talk about, right, that the hyperfragmentation in medicine has led us in our mind to fragment the person. So we've like fragmented the person effectively in the way we view medicine. I'm actually talking about St. Newman, end up with a paper next week at the Conference of Medicine and Religion sort of about this, about the idea of university and the encounter with the entirety of knowledge, and we have to encounter our students and our patients in that same way. But we are so specialized, right, that we oftentimes have our care that we consider biomedical, and then the chaplains or the clergy are operating this sort of other side, and we have like no idea what the other is doing, and like that's just not great. So Jessica Zitter writes about this in Annals of Internal Medicine, which is a journal that has this really cool section about being a patient and about being a doctor. And she wrote in this on being a doctor. She's a palliative med doc who sees a lot of dying people. She would get the chaplains to come see her patients, and she would just leave. She had no idea what they did. I remember when I was a medical student resident, I knew the chaplains would sometimes come see my patients. I know like a note would appear in the chart, but like I honestly didn't really know how that happened. I never read the notes. It was some kind of parallel system, right? So one of the times she actually stayed in the room to witness what the chaplain did. And she said, even when our medical expertise isn't required, our presence in the room is, right? Taking the time to witness a patient's suffering and acknowledge a patient's prayers is itself a therapeutic act. And it humanizes the medical system and creates a foundation of trust for the patient. I just thought that was really beautiful, because we know, right, that like the trust for certain populations in our healthcare system has been broken. And we want to recognize the importance of trust and physician, patient, and healthcare provider patient relationship as a really important thing, which is shown to be predictive of like patient adherence, agreement with the care plan, engagement with the healthcare system when they need it. So we should do what we can, right, to like, even if we don't believe in these things, right, we should be able to legitimize these practices that our patients have and show our patients the respect that they can bring this into our medical system and be supported in the way that we can do so. Theme 3 was just like, people have no idea. When I give talks like this, they're like, what even is spiritual care? Like, I don't know, And so someone said, I think one of the barriers, honestly, is people not understanding exactly what spiritual care does. And perhaps, what is this whole concept of spirituality, right? I don't think I'm alone in thinking, having a certain preconceived notion about what it means. You sort of call the chaplain, so maybe more education is needed. So I was giving a talk in Cleveland last weekend to the Cleveland Christian Catholic Medical Association of Northeast Ohio, and there was a priest that gave a talk before me, and he was talking about what do priests do when they come into the hospital, and he's like, people misunderstand. He's like, oftentimes the nurses, he said, will see me come in, and they'll be like, oh, Father, like someone's about to have like a really bad day, and he's like, what? He's like, I'm just here to like see my parishioner who's like in the hospital, And so like our folks thought too, right? They think like, the chaplains are for like, if you are actively dying, you call somebody. Otherwise, like, what is it for? But honestly, we know our chaplains actually can attend a patient suffering, new diagnosis, transition in care, right? Status change, right? Difficult conversations with families. Our chaplains are like amazing, right? So people just don't know what spiritual care even is, or what does spiritual distress look like. You have a patient who maybe has like an emotional reaction that's maybe out of proportion what you think is going on. That could be a sign, right, of spiritual distress. Good to get your chaplain to come by. Time, right? Sometimes by necessity we focus on the physiology, more concrete medical care, because that's what we're supposed to do, and it's what we're comfortable with, right? In med school, you learn a lot about controlling people's blood pressure and giving antibiotics more than you do about spiritual care, right? We're very comfortable with what we can measure, what we can see, right? More so than like these other concepts that are very uncomfortable. And as Salmese says, you cannot give to others what you yourself do not have. So people who have more of a deep spiritual life or have thought about these issues themselves are going to be more likely to engage with others in this space. And 5, like, it's just not on people's radar. So in the ICU, we have this like ABCDE bundle, and they're like, maybe we get to F for Foley and feeding, and maybe G is for God, right? Sort of not on people's mind. So we wrote about this in the Annals of Internal Medicine, and we said, it was a sort of a call to action. We said, we sort of asked the question, but our answer to this question is yes. It is time, right, to more fully address teaching religion, spirituality, and medicine. And so in the piece, we say, our patients believe in God. They think it's very important, right? They have this worldview that's going to influence how they make decisions in our care. We completely ignore this. We need better training. And we make this analogy, which I think is helpful, to the sexual history. So maybe not that long ago, honestly, 15, 20 years ago, I remember people saying, oh, I'm not going to ask my patients about sex because it's not my job, or it's too private, or it's not related to medicine. And now, of course, we have very standardized questions to ask people about their sexual health. We incorporate it right into our history taking. So I think the spiritual history sort of is like the last taboo in medicine. Hopefully it'll be something that we ask people about routinely because we know it's related to their care. So if nothing else, I have some people usually in the audience that they care about cost. They care about money. They're like, this sounds great, Kristin, but is this cost saving? Is this something that you think is going to just sort of cost us more time? I don't like these conversations around money per se, but if you need that information for your folks, there's a really nice study done by Tracy and Michael Baboni, who are at Harvard. She's a radiation oncologist. He's a theologian, and Tyler and crew at Dana-Farber. And they found actually the end-of-life costs were higher when patients reported their spiritual needs were inadequately supported by a couple $1,000s a patient, actually, particularly amongst minoritized patients and high religious copers. So we decided to write about this in JAMA on maternal medicine. They have this really cool section called the teachable moment, where basically we sort of take something in the clinical space and provide some kind of clinical pearl. And we talked about how do you take a spiritual assessment of your patients? Why is it important to do? There are many spiritual assessment tools that you could learn. We talk about the HOPE approach to spiritual assessment in this piece. I use the FICA assessment because I'm an outpatient doc, and the FICA one is more validated for the outpatient setting. It was developed by Kristin Pochelski, who's the leader of the GW, Institute for Spirituality and Health in DC. And FICA is an acronym. It stands for FICA, faith, importance, community, and address. And so whenever I ask questions like FICA, or I take any type of sensitive history, right, you always should do the 2 Ps, right, the purpose and the permission. This is the reason I'm asking you these questions, and then is it okay if I ask you these questions, right? Because there is a power difference, a hierarchy, right, between oftentimes you and the patient. You don't want to force them to think they have to provide sensitive information. And a lot of people actually have a history of religious trauma, and you don't want to wade into that unless they feel ready to do so. But the 2 Ps, and then the F is for faith. So I ask people do you have a faith or spiritual practice, right? The I is importance, Some people on a demographic sheet might mark Catholic, but when you ask them, it's not really that important to them and how they make decisions and such. C would be community. Do you have a community of people around your faith practice or your religion or your spiritual practice that provide a sense of a community for you or engagement, or do you get support from these people? What does that look like? And then A is address. As your healthcare provider, how can I address your religious and spiritual beliefs in your healthcare plan, right? So that's the patient-centered sort of question. So you can ask those questions, and I think of other tools that you can use here. Dan Hinshaw gave me the question I probably use the most, which I think is really helpful when you talk to patients, which is, are you at peace? And I think that question is so beautiful because the answers you get back out of that question are things we probably should know about, that maybe just the patient otherwise hasn't had an opportunity to tell us. So are you at peace? And also I think about this space, about a time to remind us to think about religious accommodation. In our hospital, if you sit on hospital planning committees, or if there's going to be a new building built for patient care, how are you going to provide space and resources for accommodation? So for example, we think nothing of providing vegan, vegetarian meals. Like, do you provide halal meals or kosher meals for your patients? Like, why would we think of that any differently, right? Do you provide space for prayer, do you have access if people come in emergently and they figure out their Bible, or they need a rosary, or they need other religious items? Like, can you provide that, right? If your patients, respect the Sabbath, like, are there policies in place for them to be able to actually observe the Sabbath in the hospital? Because again, people's religious lives like shouldn't have to stop when they're in the hospital. And obviously, they're going to be disrupted in some way, but like this isn't the place to like make sure that doesn't happen. Are you allowing clergy and members to come in? How connected are you to your community clergy, right? So I just want to sort of switch gears briefly in the last few minutes. We're going to talk more about this tomorrow and think about physician burnout. So physician burnout's a huge problem, right? And not only with physicians, but nurses, other healthcare providers. And actually, we know from data that a lot of physicians believe in God. So people are surprised by this. And a nice sort of percentage of people actually went into medicine because of their religious spiritual beliefs. And then what happens is they get to us in medicine, and we make it seem like they have to check their faith at the door to be considered a legitimate scientist. And we'll talk more about this tomorrow, but that's absolute nonsense, right? And especially if we think about burnout, it's a very complex problem, but burnout's oftentimes anchored into a loss of meaning making, right? And many physicians, right, who have a religious background are going to have a sense of meaning making through their religion and their spiritual practice. So then why would we take that like very strong pathway of meaning making away from them, or make it seem like we have to take that away from them in the vocation that's going to like put them at risk for burnout, right? It doesn't make any sense. We know from much like cool research from Parker and Ben Doolittle, Yale, and others that actually at any level of training, medical student, resident, fellow, attending, actually, the people who have religious spiritual beliefs actually do better. They have like less risk of burnout. Their coping skills are like strong. We wrote about this in JGym. We'll talk about this paper more tomorrow, but we wrote this piece about the role of spirituality and religion in physician training wellness. But like, I just, I sit on a lot of like med school committees and such, and we talk about wellness, and it's so important. But if we think about wellness as like a wagon wheel, and wellness is like, let's say the nirvana of wellness is in the middle of the wheel, and there's like all these spokes that come towards wellness, we legitimize all these spokes, yoga, meditation, running, napping, and that's all great. I mean, that's all, I love that stuff, right? But like, what about the folks that have a religious and spiritual practice? Why can't they have that spoke be legitimized in these wellness conversations? What happens, I think, is that people who have these beliefs are either made to think they have to like prune that spoke off their wheel to be considered a legitimate scientist or an academic person, or they better just sort of like shut up and not tell people about it. Because if you tell people you have that like religious and sort of or a faith identity, people are going to think that you're whatever, It's part of the hidden curriculum, So what I try to do in like the work in our program and some of the talks, especially tomorrow we'll talk about, is like you shouldn't be made to feel like you can be like a Catholic on Sunday and a physician, let's say, Monday through Saturday. But what does it look like to be a Catholic physician like every single day of the week? Like, what does it look like to have and to model for your learners like an integrated professional personal identity? Especially if we're going to say we want diversity, right? We should be able to model that for our learners. Just like I wouldn't say to you, like, you're a mom in the evening and not a physician. I'm a physician mom like all the time, Like, what does that look like? Why aren't we doing that, So just lastly, in terms of DEI, especially as this relates to bioethics, this was a tweet that I saw not too long ago by, I think she's an attending, and she said, "Last weekend I spent an entire day trying to figure out what to tell an M4 student, a senior student, who asked me if she should wear her hijab in her AIRS photo and how that would affect the interview she got in a competitive specialty. I must have told 10 residents attendings about this topic. This is draining." So I hear a ton from students across the country who reach out to me and say, Dr. Collier, like I'm Catholic or I'm Jewish, or I'm a Muslim, right? And I have been told by my dean of my medical school that I better not have anything on my application, right? That will let my program directors know that I'm like I say, I'm Christian. I want to go into a competitive specialty. I want to do plastics. I want to do neurosurgery, right? I want to do IR or whatever. And I can't threaten anything, that's going to threaten my ability to match in a specialty. What do you think? What do you think? And I've been getting more involved in like talking about physician conscience and how physician conscience is like under threat, especially in places like Canada and here a little bit. And you hear from folks that are working in the space that like certain groups in academic medicine are like actively trying to identify students even before they get to med school. They have any religious leanings and sort of like weeding them out. They don't want, right, folks that have convictions that are going to sort of come up to sort of disrupt access to certain types of care. And I would say if we're going to talk about DEI, like why would we like be like, you can be diverse in every single way possible, but like, I'm sorry, religious diversity, I'm sorry, no. You know, you can't be here, right, as a Christian Catholic person. Like, well, that doesn't even make any sense. So if we truly want to have a healthcare force that represents, right, the types of patients we're going to see, and in the spirit of DEI, like we should be embracing all of our brothers and sisters in the field and not discriminating based on religion. I mean, that's awful, but these are true stories, right? And you think about bioethics, you know, people I know, Charlie Camosi gave the talk last semester before me. He talks a ton about this. He's a bioethicist, and he feels like, as a theologian, he's like marginalized from a lot of conversations, academically, at conferences, at certain, you know, policy groups. I mean, these are like, I mean, the dignity is a useless concept is an older piece, but, you know, the American Journal of Bioethics, you know, about a year and a half ago had a whole journal sort of dedicated issue about basically why we shouldn't reestablish a relationship between theological and secular bioethics, right? And maybe theologically grounded concepts may not provide the necessary intellectual resources to discuss inequality and justice in healthcare contexts. So there's this narrative, right, that if you have a theological-based ethics, you better just sort of like go away. And we'll talk about this tomorrow, but we have something, again, really radical to say into the space of bioethics, those of us that have theological claims. And again, we're not prescribing religion and spirituality to anyone, right, in terms of like the wellness piece or this. But for those of us that have those convictions, why would we be excluded from important conversations? We have something really important to say, especially around human dignity and the value of human life. And this is one example, right? Many of you know there's this controversy going on in different circles about brain death and about the Harvard Brain Death Committee and how this relates to organ transplantation and all of that, which is beyond the scope of today's talk. But, you know, in most states, right, brain death and cardiopulmonary death are considered to be sort of the same, except in states where certain religious folks have stood up and say, we disagree, specifically like in New Jersey, where actually, you know, brain death is not considered to be the same as cardiopulmonary death, and the Orthodox Jews do not believe that their brothers and sisters who are brain dead are dead. And there's been conversations ongoing about this, so we can sort of think about this as we go forward with policies, because these policies affect people's lives. So we'll talk about this tomorrow, about how we can obtain through discernment the mind of Christ, and how our view of the human person, why that matters, and if we don't have the right view in terms of the importance of human life, people's lives are at stake when we think about policies and bioethics and decisions that are being made. And I'll give examples of that tomorrow. So just to end, I just want to end with Camosi, because he's, the reason I'm a pro-life person now is because of Charles Camosi and the way that he engaged with me over time. I was telling Brian about this on the way over here. And he's helped me think so deeply about big topics related to life in medicine. But I just think, you know, he reminds us all the time when we think about, do we deserve a seat at the table, at a bioethics table, at making policies as a Christian person, he would remind us that there is no view from nowhere. Everyone's coming to the table, right, with the perspective of a normative tradition. Everyone comes to the table with their first principles, right? Such first principles claim the thinker by faith, intuition, or some other authority. This is true whether you're a utilitarian, a Kantian, a feminist, or a Roman Catholic, right? And especially an ethical tradition is only as rich as its vision of ultimate meaning. And in medicine, where meaning is at the heart of what we do, the religious traditions, which are also steeped in meaning, should continue to inform bioethics if we truly care about the sacredness of human life and the dignity and equality of all human beings. I'm going to end with this piece. If you haven't read this piece, it's excellent. So Nigel Begar, he's a professor, he's a theologian. He was at Oxford. I think he's maybe still there, but this was a piece in Journal of Medical Ethics a few years ago. This piece was actually a couple weeks ago. I was guest lecturing in the Religion Bioethics course at Loyola Marymount, Dr. Brown's course, and this was the pre-reading. I couldn't believe I hadn't seen this piece before. But he goes through this argument, right, about why religion deserves a place in secular medicine. And basically the argument goes, and we'll end on this, is that, you know, for so many years, right, there's been this narrative that like religious people don't deserve to be at the tables of academic institutions, at policies, ethics, and that kind of thing, because we're somehow uniquely awkward, right? So we basically have claims of faith, right, that basically outstrip our ability to prove them with like empirical science and that kind of thing. And in the piece he says, everyone does that. You can talk to your friends who believe in, like, in the unstoppable, they have their own faith, right, in the belief of the unstoppable progress of human history, right? Or they'll have faith that, like, very strong faith that, you know, we're going to be able to, like, through transhumanism and technology, overcome our mortality, right? Or they have unending faith in the progress of, like, science in some way. Those are all faith claims too, right? And so he says, you know, the secular space defined, you know, in the modern version of secularity is not and should not pretend to be some kind of neutral sort of zone that transcends conflict. And if you just remove the religious folks away, it's going to be like this bastion of peace, right? He's like, the philosophical schools are still going to like come together and have disagreements over core foundational prospects. And that's actually what you want, right? If we go back to what he says is this Augustinian conception of secularity, right? That's more consonant with a generally liberal, plural political idea than the dogmatic, sort of anti-religious, sort of modern secularity, right? We all are coming to the table with our first principles, and it's hypocrisy to say that we should just like remove the religious folks if we're somehow uniquely awkward. He's like, guess what? Like, we all come to the table with our first principles, and we all have faith claims that we cannot prove, etc. When we had this session with the students at Loyola Marymount a couple weeks ago, this one young lady was like, but Dr. Collier, like, I just don't like this language, right? Because he says in the piece, like, to persuade, one must become persuasive. And she's like, are we really trying to persuade people? Like, what do you think about that? And it was like, I was guest lecturing by Zoom, and it was Loyola Marymount, which is in, like, California. So it was like 11 o'clock my time at 9. I just sort of hosted this webinar. So I was like a little bit punchy, you know? And I was like, sister, I'm like, people's lives are at stake. We actually have something very important to say about the violence of abortion and the violence of like medical aid and dying, and how like killing should not be part of healthcare, and like the value of all human life. We actually have something really important to say, and people's lives are at stake. So sister, I think it's okay to be persuasive. You know, that's what I said. So then tomorrow what we're going to talk about actually is sort of a theology of medicine. So thinking about how to discern our vision of the good, especially when it comes to bioethics, and how to look to Christ as the divine physician to shape our theology of medicine. We're going to talk about Imago Dei. We're going to talk about incarnation theology and like why matter matters, nonviolence. I have like a lot of Renaissance art and stories from the scriptures. Hopefully you'll join us tomorrow morning. But tomorrow is like my sort of more personal talk. But I thank you for your attention. I think I'm right at the hour maybe. End of my rest slide. So if people are wondering what this rest slide is, this is when I was sick with COVID-19 in 2020. I was so sick. I was like, you know, by myself, couldn't breathe. It was like really awful. And this is a piece from the St. John's Bible. So the only thing I had actually during that time that I could sort of like watch and listen to was like this McGrath Notre Dame sort of story coverage of the St. John's Bible. And this was a picture of Genesis. So it's like the 7 days, and it's the progression from chaos to sort of the Sabbath. So that's what that is, if you're wondering. Thanks for your attention.